Well, welcome everyone. I'm John Lohman, a physical therapist at the University of Alabama at Birmingham, where I'm working the adult cystic fibrosis clinic. Deanna, or Dee, and I are excited to kick off this workshop for you on the final day of NACFC. We're excited to see this many people in a room on a Saturday, especially knowing that college football has already started on the East Coast, and you could be watching football somewhere maybe. Just to remind everyone that today's session is being recorded. So if you have questions at the end, either use the app or come to the microphone. That way we can kind of get your question recorded. Again, we hope y'all have had a great time so far. Have learned a lot, connected with some old friends, and made new friends as well. So now allow me to introduce Dee, and then turn it over to her to kind of introduce our session as we get going. So Deanna Serna is a respiratory care practitioner, respiratory therapist, respiratory therapy manager for pediatrics and adults at the University of California, LA CF Center, and where she also serves as a research coordinator. She has extensive clinical expertise, is a registered respiratory therapist with a specialty in neonatal and pediatrics, and is also a certified asthma educator. Her dedication to advancing respiratory care is evident through her commitment to patient education, interdisciplinary collaboration, and innovative treatment approaches. She has been a frequent speaker at NACFC in the past, and she has a wealth of experience, passion for improving patient outcomes, and providing compassionate care. And lastly, I might add that this session would not be happening today if it wasn't for her, because she put in about 99% of the effort for this session. So thank you, Dee.
Real quick disclosures, I did receive the Research Champions Awards for this year from the CF Foundation. Nothing for John at this time. Long title here, but really to boil it down is non-modulator eligible advanced lung disease patients. This workshop will feel different than workshops you've been in the past. Historically, we hear from fellow PTs and RTs, QI, and different treatment options. When we reviewed the abstracts, and there were wonderful over 850 abstracts, there was a lack of source material regarding this patient population. And that was not PT, RT, that was across the board. And so in collaboration with our organizing committee, we did a little pivot. And so you will hear from speakers that don't usually speak to the RTs and PTs. So I think this is a wonderful opportunity, because the information is really, really fantastic. The lack of submissions, really, it's not that we're not doing this work, because we are. It might not be every clinic, though. Because when you look at the numbers, just looking at my center, we have 197 patients who are CF. 34 are classified as ALD, and only 4, oh, look at that mistypo. But of that total, only 2% of those patients are ALD non-modulator eligible. And so I can see where it becomes challenging to think of writing about these patients. It's not new or revolutionary. It is the standard of care. So we made a little shift. And also I wanted to, it doubled. I note that the session objectives changed. What was put into the planning was what I had hoped and what we looked for, but this is what we ended up with, and I think it's really fantastic, because we get to hear from a person from the registry talking about our essential role in the care of these persons who are ineligible or unable to take modulators, learn how to better utilize this data to inform our care, 2 great studies about how they're feeling, because we you know, when a person is in front of us, a lot of times they don't want to appear sick or appear that something's wrong. And so they tell us that everything's fine, but underneath the surface. And so I think it's really important that we hear from these studies what their real lived experience is. And I think that will help better inform some of our communication. And then the last part is looking at what might be the only treatment option for some patients, and that is transplant. And so hear from a team on how they worked to integrate between both the CF team as well as the transplant team. So we have a wonderful group of speakers. And I really thank you for indulging in this little deviation from what is the norm. And I will turn this over to John. And a little bit about John. This is a very busy man. He has not only a master's in physiology, but as well as a PhD, or actually the master's is in physical therapy, and he serves as an educator. He's worked with not only our foundation, but the European Cystic Fibrosis Foundation. So very busy man. So yes, I might do a lot of work, but he does a lot of work. I'll turn that over here.
All right. Well, first up, we'd like to welcome our first speaker, Abigail Boyle. Abigail is a program manager at the CF Foundation, where she's been working on advanced lung disease and transplantation for almost 4 years. She got her nursing degree from the Catholic University of America and master's in communication at Johns Hopkins University, and has worked in worked as a nurse in pediatric critical care. She's going to share with us about advanced CF lung disease, other comorbidities, and how advanced CF lung disease has changed over the years. So welcome, Abigail.
Break anyone's ears. Good morning, and thank you for the opportunity to speak today. My name is Abigail Boyle, and as stated, I work on the Advanced Lung Disease and Transplant team at the Cystic Fibrosis Foundation. My focus for today will be understanding advanced lung disease and CF throughout the patient registry data that can inform clinical practice and also uncover unmet needs in care and research. I have no disclosures. So the objectives of this presentation, I think partially is to get some abstracts flowing for next year, but also some more detailed objectives are stated here. So to define the key characteristics that categorize advanced lung disease, and then to describe the current demographics and clinical profile of the advanced lung disease population, to evaluate CFTR modulator eligibility within this population and explore variations in outcomes, review lung transplant referral for this population, and then highlight the process for registry data requests and its role in advancing ALD research and care. So how is someone deemed to have advanced lung disease? I'm sure a lot of you are aware, but just a little refresher. So published in 2020, the CF Foundation Consensus Guidelines for the Care of Individuals with Advanced CF Lung Disease describes the following. So it includes an FEV1 less than 40% predicted when stable, when stable, or referred for lung transplant evaluation, or one or more of the following below. So this is a great guiding tool, but there are other areas that clinicians may note and determine an individual to have advanced lung disease. Something that we see frequently is repeat hemoptysis. Now, as all of you know, as an individual with advanced lung disease does require the standard of care, but they also involve the standard of care plus some. So this visual just kind of is a little example of how that happens. So in the area of modulators, we may see individuals with lower FEV1s living a life they are comfortable with. Despite this newfound comfort, we must remain hypervigilant. This can be a time to educate, inform, and optimize care. So if the need for transplant arises, all parties are prepared. I also want to highlight heightened management of ALD-associated comorbidities, especially as we begin to see this population age, as we saw in our plenary last night. And a personal favorite of mine is palliative care, reminding our patients that palliative care is not necessarily end of life, and there's a way to optimize their life in this process. Now that we have a clear understanding of what ALD diagnosis and general care needs are, I want to draw your attention to the CF Foundation Patient Registry Report, highlighting individuals with ALD from 2020 to 2024. Specifically to this, all the way to the right is the 2024 column, and this is data we currently have on the ALD population, so what they look like today. In the CF Patient Registry, there are about 2,497 individuals with ALD, 211 which were newly enrolled this year. Their mean age has grown throughout the years, landing at 39 in 2024, with the majority of this population being older than 18 years. We also have data on race as well as gender, and then lower on the table, you will see the FEV1% predicted, a mean of 43.1. This table demonstrates the interventions and tests. Oh, sorry, let me go back. Here. Oh yeah, so this one is actually the multidisciplinary care team members that are seeing these patients in the ALD population. So about 90% of all of you are seeing these patients, but a much lower percentage of patients are being seen by pharmacists and a mental health coordinator as seen below. So this aligns closely with the general population, general CF population who's seeing them, but the mental health needs of individuals with ALD are increased, as we will see shortly. So this table really describes the interventions and tests being performed in this population. Highlighting in 2024, again, all the way to the right, about 20 to 25% of this population have had an echo, and then about, I could give you specifics, 21.5% at least one blood gas analysis performed, and then about 25.9% at least one 6-minute walk performed. So this variation may be due to the higher mean FEV1% predicted value that we saw earlier, but guidelines state that individuals with CF and an FEV1 of less than 40% predicted should obtain an annual 6-minute walk test and an annual blood gas to screen for markers of severe disease that may warrant transplant referral. So again, being hypervigilant with this population. This table breaks down the complications of CF across the varying aspects. So you see, starting on the left, we have CF population, ALD population, and then to the right ends in lung transplant population. And for me, I'll focus on the ALD population. So each complication, truly every single one, is increased in the ALD population, some of which increase even further for those who have undergone a lung transplant. A few to highlight that are predominantly increased in this ALD population include CFRD, osteoporosis, anxiety, depression, and hypertension, just to name a few. So now that we have a better, deeper understanding of this population, let's review their eligibility for modulators, specifically by race. As seen here, although a smaller percent of the population entered into the CF patient registry, the Asian and Black population are less likely to be eligible for modulators in comparison to the Hispanic and white population. Those can be seen in bars, the second and third bar. But how does this impact their lung function? For all races, as expected, those on modulators have a higher FEV1% predicted compared to those not on modulators. This is significantly noted in that middle column there under the Black population. As you see, the blue bar is those modulator use median FEV1% predicted, and then the orange is no modulator use. As I mentioned, we need to be hypervigilant with this population. We cannot be made too comfortable in the presence of modulators. This graph demonstrates those in the ALD population not being referred for transplant in 2024, broken down by race. Removed from this graph, due to its kind of skewed the graph overall, but was those who were deemed too well. So what does this really mean? I encourage you to go back to your centers and really analyze that. What does that mean? What is too well? Are they too well based off FEV1, other characteristics? Are you getting these screenings that should be occurring? Also seen on the x-axis, there is a vast range of other reasons patients are not being referred for transplant. Decline to pursue, again, what does this mean? Adherence issues, limited social support, substance misuse, and mental health. Some of these just absolutely break my heart personally, so I encourage you again to look through these. Which of these are modifiable barriers? How can we start the conversation with our colleagues and transplant centers around us? So now, throughout this presentation, I did not draw conclusions, but I do hope I sparked your interest. What questions do you ask yourself and want answers to? I know for myself, I would walk around the pediatric intensive care unit as a bedside nurse, asking myself questions. Why is this the method? Why is this practice? How can we improve it? But I didn't have that data to support it or really analyze any of these questions. But all of you have this data available, so I encourage you to investigate the question you may have, develop a project, and submit a data request to the patient registry team. This can be found on cff.org. If you search in the bar, patient registry data request, or something along that, it will populate for you. So through a collaborative process, you'll obtain the data you need to present a poster or presentation at NACFC 2026. I hope to see you there. And as a final note, data is powerful. Data can inform clinical practice and uncover unmet needs and improve the care of all people with CF. Thank you for your time and attention and all of the work that you do for the advanced lung disease community.
And Abigail, if you want to stay for any questions?
Just at the end.
Yeah, we'll have kind of questions in between. So any questions for Abigail?
So, real quickly, with the data that's had, so all of us know and understand, like, how does this impact, like, further, like, treatment plans or, like, initiatives, like how we have the post-transplant iLab? In what way is that used, like, for this population, because they're not quite to the transplant?
Yeah, I think a lot of the work that we're doing, and she's referring to some QI work that we're doing, we can use this as preliminary data to then investigate a bit further what's happening at these care centers directly. So we're looking at program CF care centers, but also transplant centers. But in this case, if we're looking more at ALD, I think this is a great future opportunity to analyze further this population in a QI aspect of what we're seeing in this patient registry data. Hi, Kelsey.
Hi, Abby. You mentioned that palliative care is an important part of advanced lung disease. I was curious, what would you want patients to know specifically about palliative care that they may have a misconception about, that you could kind of, encourage them to look into it?
Well, I'd love when they are deemed to have advanced lung disease that they already know what it is, because at time of diagnosis, I think it would be a great opportunity to understand what palliative care is and really optimize their health throughout this whole journey. Any chronic disease, illness, it's a great way to introduce palliative care and create comfort, and it's really optimizing your day-to-day. So it's not end of life, we're not removing care, we're optimizing it and improving how you're feeling. So I think that's a great way we definitely need to change the narrative behind palliative care.
Yeah, I was actually going to ask a similar question. So now I'll just kind of make a comment, since you did a great job kind of answering that. When I always had the perception that palliative care was kind of end of life until I started doing some work with the foundation and kind of got awakened to what it really is, and especially as RTs and PTs, and given the plenary that was last night about kind of aging in CF and all the things that we can do kind of early on from childhood to exercise to build bone mass and muscle mass, that's palliative care, right? I mean, we're taking care of somebody with a chronic condition, even in childhood, that might have a perfect FEV1. That palliative care is getting their optimizing their health at a young age so that they can die of colon cancer at 90 years old or something, So that was a good one.
We do have a question in the app. With less lung transplants being performed, is a lack of transplant centers possible in the future?
Well, I think they're always, although CF transplants are decreasing, lung transplants overall are increasing. So there's specifically the larger lung transplant factor, they'll still be around. But I think it's something to consider that there is an expertise in CF lung transplant, and who has that expertise, who has that ability to complete these surgeries. So something to consider as we move along and see these numbers decrease. Again, in the era of modulators, who knows what the trajectory will be of these patients with advanced lung disease. Maybe as everyone ages, there might be a greater need for transplant as well. So we'll definitely just have to take it year by year.
One last question for you, related to, since some of the RTs and PTs in the room are the ones doing the 6-minute walk test. Is there should, when folks are getting, maybe, I don't know what FEV cutoffs, like 50%, I mean, should we be like asking the team, hey, do you want us to do a 6-minute walk test on this person to see if they're at that threshold? So that's kind of part one. And part two, is there a low threshold below which you're not eligible for a transplant? Like, is there a certain distance you can't, you need to be able to at least walk this before you're eligible?
Yeah, I think it's I'll go to your second question first, and then I'll go back to your first one. But in terms of eligibility for transplant, it's very variable based on the transplant center. So we always say if the first one is a no, you could go to a second one and ask them what their qualifications are. I don't think singularly the 6-minute walk test is a factor that will determine that for a transplant center to say, okay, we're a go, we're not a go. There's so many factors involved, as you saw, a lot of those reasons why patients aren't being referred. And completing those or being listed, all of that. So I think it's multifactorial for sure, but something to consider as you go throughout. And then in terms of if they're at 50% FEV1, definitely starting that conversation with your team. If they had a quick dip recently, just kind of addressing it, flagging this person for your team to say, okay, this is maybe a high priority. We really need to watch them closer. Again, hypervigilance.
Sorry, hi, Matt Bowman from Syracuse, New York. We don't have a transplant center in Syracuse, so we send patients all over the Northeast. It could be Cleveland, Pittsburgh, New York, Boston. But I would see patients pre and post transplant. So oftentimes I'm calling them and say, what do we need? And again, it varies certainly between centers, but it was usually approximate 1,000 feet. Saw with someone last night, 400 meters, which math-wise is about 1,200 feet. And when I'm in the adult center or the peds, depending how ill the child is, we're looking at about that 50% to start to get that baseline and start to encourage that strength and especially strength and endurance work to get them up and tell them the importance of that, especially if they have started to have, if the other team members have had that conversation on transplant.
Yeah.
So then I can feel comfortable saying, okay, I know it started. You need to work on your strength and endurance, because I have seen pre and post so much, and the amount of muscle mass and strength that they lose. I had a guy who used to be able to lift the whole leg press. He was as strong as an ox. It was incredible. And when he came back from his transplant, he'd lost a ton of muscle. Those are, I'm not saying that is the definitive, those are the definitive numbers, but that's about what I've been hearing from a couple different centers.
Thank you. Yeah, that deconditioning can be significant after a transplant. Yeah. Thank you.
Yes, thank you, Abigail. And as Abigail alluded to, there's a lot of rich data in the registry that we can use kind of for future research. Thanks for making a plug for our abstracts for next year. But how did that data get there? So next, I'd like to introduce Donna Germuga. I should have asked that in advance. Thank you. Donna is a respiratory therapist and currently serves as the program coordinator at the University of Rochester's Medical Center's Adult CF Center. She's had over 20 years of experience working in cystic fibrosis and has been a frequent presenter at NACFC and serves on the planning committee. So thank you for your service there. Today, she's going to share her insights about how to best assess and document people with advanced lung disease. So Donna.
Thank you for inviting me, and thank you all for getting up early. Who on the last day of the conference doesn't say, let's look at how to enter data? I have no relationships. Abigail went over the definition of advanced lung disease. This data entry kind of in the weeds stuff may seem dull in comparison to all the information that y'all have been taking in this week, but this is where sort of the flow of information starts. It's an important place. It's a chance for teams and researchers to look at patients from across the country who are awaiting a time then they may have to make some really big decisions, and hope that recognizing important changes that are leading up to that decision can be identified and maybe put that decision off for a while. So while it's not sexy, it's important to look at, and let's look at what we need to do moving forward. I would say if you're not the person who's doing data entry, go back to your teams, because the person who does the entry may or may not have clinical experience, and if you can maybe build some of these things into your electronic medical record for the providers to put in there the last time the patient had an echo or something like that, it makes it so much easier for the person entering data to be able to accurately document. So the forms, there is a specific section of Port CF that is specifically for advanced lung disease data capture to better differentiate those who are stable and those who are experiencing some sort of rapid decline, whether it's a new pneumothorax or hemoptysis or whatever. So there, in the registry, there's a one-time initiation form, and there has to be documentation in the patient record of a discussion of ALD and what the criteria used is going to be. The patients are identified using the criteria per the consensus definition, which is the one that we reviewed before. If a patient begins modulator therapy and their baseline increases above that 40% predicted, they will continue to be followed in the advanced lung disease registry so that, as time goes on and we look at more information, we know maybe what's precipitating some of the changes that lead to transplant. So this is the initiation form. Again, the date patient flagged for ALD is going to be the date that the provider documents the conversation happened. Again, I would encourage all of the providers to have something for the EPIC, it's a smart note or whatever that defines what made them bring up the conversation. And then there's all these things, you can choose as many as you want, and you can also specify other reasons if you want to. So just an important fact that if somebody was diagnosed as advanced lung disease before 2019, when the ALD registry started, we're putting in the date as 1/1/2019 and then moving on from there. There's an annual assessment form, and it's in a couple of parts. One is clinical advanced lung disease, the overall status, and then each year you start a new form. The interventions page, you can see that pretty well. And it just basically asks these questions. It's a yes or no. Has the patient had a thoracic procedure? And the types are listed below. And if you don't know, if the patient was maybe at another hospital or something and you don't know, you can always click that button. Were they enrolled in pulmonary rehab? And again, that's something that might be the thing to click you to say, oh, maybe we ought to think about talking to this person about pulmonary rehab. Have they seen a palliative care specialist? And then why? What was the reason for that referral? If they had an embolization for hemoptysis, and I circled this little thing over here, if it happens more than once, you can just create a new entry. You create an entry for each time an occurrence happens. Were they admitted to the ICU? And then the date of admission, the date of discharge from the ICU, why were they intubated? And, they're trying to figure out if does that portend something for the future of all patients, or is this individualized? Oh, the right heart cath. They want a lot of information from that. And, depending on what the report looks like, I can't read these things. I look at the note. You can discuss it with your providers to see if they can figure out all these different things. But this patient did not have a right heart cath, so I didn't have to do that. The 6-minute walk, again, if you're doing multiples of those, often the transplant center wants them every 6 months if they're being followed. So you can just add a new entry. If they had a blood gas, every blood gas they've had, they want to know. The first one there you can see was the patient's worst blood gas in a year. And then the second one was in a stable state. So these were arterial. You can choose venous. Was transplant discussed with the patient? Yes or no? Again, we need a date in the chart that that says that. Transplant referral and evaluation. This patient was referred to transplant. We're in Western New York, so we don't have a transplant center. This particular patient, interestingly, was denied insurance coverage for a visit to a transplant center because they wanted the patient to go to the hospital in Buffalo that doesn't do lung transplants. So we really, you got to look out for this stuff and go back and try and figure out how to help. The patient was deferred. Was she removed from the list? No, but the insurance denial was really the reason that she wasn't kind of actively pursuing. The clinical context, the annual form. They want to know if they're trying to, I guess, tease out if we're performing all these things. So somebody has to look at the form and say, oh, we haven't done a 6-minute walk, let's do that. And you should enter them as they happen. There are rare occurrences, there's transplant information, and these things are just, you only need to report once as they happen. This is that's all information that shows up on the form. And then again, how does this impact those who are not the data inputter? And it's understanding the requirements of the foundation to help us understand how and when to identify patients that need this discussion. If a patient does wish to pursue transplant, even if it's far in the future, it's important to have time to acclimate to the idea and understand what'll be involved. More people aware makes missing important milestones less likely. And that's to say, you all may not be actively doing these discussions and this data entry, but going back from this conference and talking to your team about the importance of how and what to document is going to really lead to a more well-rounded patient care. We have had a number of patients who were sort of 11th hour, kind of fly by the seat of your pants. Would you please take the patient? They're crashing, and those, trust me, do not end well. So we also want to assure that the results have been seen and communicated to the patient. And this is just I just copied the results of the chest CT, and then that's the provider's note that was in my chart back to the patient. And so I look at that and I know, yes, the test was done and there's dates and times and all that stuff. And then also the results of that. And I, as the RT and the program coordinator, I know that I don't have to chase somebody down to figure that out. So people with CF advanced lung disease do need special consideration, even if they're stable. It takes the entire team to understand the needs of patients and monitor progression. If a patient has specific metric that's changed, they could be headed for respiratory failure and discussion is needed. Suggesting to the team when these discussions might take place should be welcomed by the whole team. And guidelines define the parameters that suggest major changes in health and inform transplant centers and will need to properly assess the patients. So actually in Port CF, where you find these resources, the main page of Port CF, you go to the resources tab, and then over on the left-hand side, you'll see the advanced lung disease data entry guidelines, and underneath the criteria for a full data set, because there is, I don't know what you call it, stipend or something given for complete data. Where to find the information. This is CF Smart Reports. You can go to your ALD data entry analysis or your population management reports. The population management report has a predefined advanced lung disease potential candidates. So you can go into Smart Reports and look at that and see if all your patients that you believe have advanced lung disease are on that list, or are some people on there in error. This is the patients. It's sort of the overview of all the testing that they want done, and you can look at this in Smart Reports to see if the patient has had has the testing that the foundation is requiring. And I love this because it analyzes the data that's been put in, and I can look down and be like, oh, this patient, patient number 2, oh, I forgot to put the ICU admission in. We need to do that. And you can go back, you open it up, you see what's there, and you can know if you've missed anything. The grant criteria the forms all need to be filled out. If somebody with advanced lung disease has had a transplant, they are not eligible for the ALD registry after the transplant. The year the transplant happened, they are, even if it happened in February of that year, but then the following year they would be taken off. And then everything has to be verified by clinicians, and it has to be documented in the EMR. If a diagnosis hasn't been made for a patient, if there's no documentation in the chart, don't start the registry. I think that's it. Takes a while, takes a lot of chart surfing, but I really think the key is having people build these into their notes of their patients, and so they can click yes or no, and you know that it's done or needs to be done. So that's all I've got. Anybody have any questions? It's pretty simple stuff.
It's very straightforward. And you're right, it's not the fun stuff, but
It isn't, no.
but it's very important. And RTs, PTs have a very big role in this
yeah.
with the making sure the 6-minute walk tests are performed, ABGs, et cetera. So even if you don't enter that data, what we're doing is
and
very
not only
high.
that, but the test that you're doing, you do a 6-minute walk test, and you make sure the result not only gets in the patient's chart, but gets to probably your program coordinator, and they get it to the transplant center that's being, you've got to make sure that loop gets closed, because you, as the center with the patient, you are the only one that can provide that information, and they don't know when stuff is done. And they can get into your EMR, but you all know what Care Everywhere looks like. It's ridiculous. So it's not ridiculous. It's hard to manage. But yeah, I think us communicating with the rest of the team assures that all the bases are covered and that we're following patients and appropriately assessing and making sure that people who need to know the results and can act on them.
Yeah, I can picture, certainly the providers are paying attention to the pulmonary function test results and the ABGs that the RT does, but maybe they don't catch the 6-minute walk distance.
Yeah.
And I can even see, so at the bottom of your list on that first page where you kind of input somebody as meeting the criteria, there was kind of the bold criteria, and then down below there were some other criteria like pneumothorax and massive hemoptysis. And I can see that maybe the RT might be the first person to find this out.
Right.
That the patient, they're doing PFTs and the patient's like, oh yeah, well I coughed up a couple cups of blood last week.
Yeah, exactly.
Hopefully they're smart enough to call their provider, but I can see sometimes they might not. So that's something that, as an RT.
Yeah, and as the RT, if you're not inputting the data, the person that is, whether it's your research coordinator or whoever, you can flag them and say, hey, just so you know, this person has been coughing up blood. I don't know if they're on your list, but it's that communication is so important, and there's just so much logistics involved. Probably less so if your CF center is associated with a transplant center, but like Matt, I send patients to Pittsburgh and New York and Cleveland, and so we have to make sure that we have those relationships. And as the coordinator, I have a lot of that, but I can imagine if I was the RT, I would want to sort of regularly kind of work with the coordinator to say, here's who we're following with this, here's what they need, here's what we're doing, and that person should be making sure that all the bases get touched. Thank you.
Thank you
Actually,
so
I've got
much.
Enjoy the rest of the
one last
day.
question for you, but I'm
sure.
not sure if you know the answer for this one, but I noticed like pulmonary rehab was on there. And does the CF Foundation kind of have a definition for what pulmonary rehab is? Because I know there's your typical outpatient pulmonary rehab that's kind of insurance reimbursed, but then I know now these days with a lot of telehealth, I mean, there's kind of unsupervised, kind of partially supervised, remote kind of telehealth services, and people are paying, kind of
Out of pocket
to work with either a physical therapist or a trainer.
Yeah, I honestly, I don't know of a strict criteria. What I know is that our transplant centers want our patients to be as fit as they can be for their lung health when they're going into transplant. So if they're deconditioned and malnourished and all those things, they're going to say, you've got to get them into a program. They've got to be actively working on this. Or, I mean, when the guy who can, bench press 350 pounds comes back and can't lift a 10-pound bag of flour, somebody who goes in with a BMI of 21 and is already struggling on 4 or 5 liters of oxygen, it's really going to be a much, much more difficult road. So my experience with our transplant centers is that they want to know the patient is actively involved in understanding the deconditioning that's going to take place and understanding the need to go in as fit as possible as their disease allows.
Yeah, and one of the reasons I kind of asked that question too is, I mean, some people are kind of seeking outside services, maybe of some of us in the room, but also I have a patient that's on the transplant list currently, and when she's in the hospital, I mean, she'll do, 15, 20 flights of steps per day. She's actually a certified personal trainer, and for her to go to pulmonary rehab, she would think it was just a joke,
Right,
because
exactly.
she's doing so much more than
Right.
what
Yeah.
she would probably be doing if she went to
Exactly.
pulmonary rehab.
And I think it depends on the transplant center. The transplant centers I work with would probably say, you're good, keep it up. But watch for a time when your level of fitness might be impaired by your level of illness.
You just covered what I was going to say. Because in Syracuse, we did not have a formal pulmonary rehabilitation program. I provided physical therapy services for people with pulmonary disease. So I always contacted the transplant centers to ensure I go, hey, it's not a formal program, but here's what I'm doing. It's strengthening its endurance. Yep, that's fine. Continue, keep us updated with your notes, so that I didn't want them my patient to be harmed in the process because I wasn't formal pulmonary
Yeah,
rehab.
yeah.
So communication, you mentioned it several times. Communication is so key in that. And the transplant centers, again, 10 out of 10 times for me, they were fine with it. So
Yeah.
that communication key of going up and down stairs, things like that. I would, for someone like that, John, I would document almost a 6-minute walk test almost every time they're in this center, just so that you've got this baseline where that patient is at, and that they're not slowly deconditioning. Because I agree, personal trainer, she's going to push herself harder than anybody else, but I think a documentation of what she can do with standardized measures would probably be a smart thing for her to do.
Yeah, and we have a patient who's non-modulator eligible, who's on 4 or 5 liters of oxygen, and during COVID was, very isolated. And she really, really did not want to go to a place where other people were working out. And so we talked to the transplant center, and I found a resource that was an online pulmonary rehab, specifically for cystic fibrosis patients. And they said, yeah, I mean, if she can do that, she's attached to her concentrator, she doesn't have to worry, all that kind of stuff. So they'll make allowances. They just want to know people are doing as much as they can.
That's fantastic to know.
Yeah. And of course, there's Beam.
Was.
Oh.
Soon to-
Thank you so much.
you're welcome.
If anybody wants to support Beam, it is an online platform, and if you've got more money than you know what to do with, and so if you don't know what Beam is, it was a kind of an online exercise platform that was initially funded by the CF Foundation and funded for many years as a platform, and then kind of in partnership with Breathe Strong Plus and some other private donors, but they're kind of running out of money to kind of sponsor the platform. So if anybody just has more money than you know what to want to do with, and you want to support online pulmonary rehab, Beam is a great place, a great resource. All right, well, moving on. So next we have Dr. Natalie West. She's an associate professor of medicine and pulmonary and critical care medicine at Johns Hopkins University, where she also completed her fellowship, as well as a master's degree in public health, or master's degree in health services, or and she's now the associate program director in the adult CF program there. She's been a co-investigator on multiple clinical trials in CF pulmonary exacerbations, and a national investigator in the Standardized Treatment of Pulmonary Exacerbations program. She's published several expert opinions and guidelines, spoken at national and international conferences, and conducted numerous clinical trials in these areas. Today, she's going to share her insights from research on the lived experience of people that have CFTR modulator ineligible status. So thank you, Dr. West.
Thank you so much. And yeah, we're going to switch gears just a little bit and not really necessarily talking about ALD, but looking at all of our patients who are not eligible for modulators and kind of hearing their voices. I do have some disclosures. I consult for Vertex and have grant funding from the CF Foundation. So this study is going to look at the lived experience and unmet needs of people with CF who are ineligible for modulators, and we use a mixed methods study. So as we all know, we've heard this over and over again, modulators are really leading to transformational improvements and health outcomes for those that are eligible. However, there's a pretty, I wouldn't even say small group, it's a substantial group of people with CF who have variants that are not responsive, either because they don't make a protein for which the modulator is to work upon, or their mutation is not responsive. And so there are some data from the registry that have looked into the clinical profile of people who are ineligible, but kind of their live experiences and their voices are less well characterized. So to fill this gap, we are using the study to characterize the lived experiences of adults who are ineligible for modulators. We're going to look at disease burden, unmet needs, quality of life, and healthcare experiences. So this was cross-sectional, observational, using some quantitative and qualitative interviewing. So to be eligible, they self-reported that they were not eligible for modulators. We just only interviewed adults who had never undergone a lung transplant. They could not currently be on modulators for some sort of like clinical trial or off-label use, and not enrolled in any other investigational study at the time. I would like to thank the Rare Patient Voice and the CFRI, because that's where we recruited our participants from. So first, they did an online quantitative survey where we collected demographics, clinical characteristics, questions about their experiences, healthcare access, and then all of these validated PROs, so patient-reported outcomes. So the first two, I think, are pretty well known in the CF world. The CFRSD CRIS is the Cystic Fibrosis Respiratory Symptom Diary, Chronic Respiratory Infection Symptom Score. That's been around for several decades, and that looks at how bad are your symptoms over the previous 24 hours. CFQR, Cystic Fibrosis Questionnaire Revised, and that looks at the impact of CF on a multitude of domains for quality of life, and that's really questioning the patient on the last 2 weeks. The CFIQ is actually relatively new. It's just validated recently, and that's the CF Impact Questionnaire. And that is looking at their perceived ability to handle all of their treatments and what's the burden associated with that. And that's looking at over the previous 7 days. And then the next one is work productivity and activity impairment plus the classroom impairment question. So that's really just looking at how does CF impair their work, school, daily activities over the past 7 days. And then PHQ-8 and GAD-7, I think we're all pretty familiar with. That's the patient health questionnaire looking at severity of depression and the generalized anxiety disorder, both looking at over the last 2 weeks. After that, we did one-on-one qualitative interviewing. So we asked them about their symptoms, treatment experiences with us as the healthcare team, access to healthcare, and how their quality of life looked. Anytime you do a qualitative interview, you kind of look at themes that are coming at, and you keep interviewing people until those themes are saturated. So for this study, we saturated at about 16 people when we kind of realized there were no additional themes popping up. So these are demographics and clinical characteristics. So the average age was 40. You can see we had 3 that were a little younger, between 18 and 25, but the rest were all over 25. Not surprisingly, majority were female. Females tend to participate in research just a little bit more of this type. And then the racial distribution, I will point out, was consistent with the general population in the US registry. However, it is not consistent with the ineligible population. So the majority, Black, Asian, and Hispanics, have a higher proportion of not being eligible. And then looking at the top right, majority were not diagnosed at newborn screening. Not surprisingly, these patients are average age of 40, so kind of before newborn screening was universal. Have a pretty good distribution of severe to mild lung dysfunction. And then looking at their exacerbations, the vast majority had at least one exacerbation in the previous year, and that was defined as needing IVs. But you'll see that 3 people had 5 or more of those episodes, so quite a sick population. So how are our quality of life scores looking? So this is the CFQR, and so you'll see on the y-axis there that as the scores go up, that denotes better quality of life. So if you score 100, you have a great quality of life. And so to the left, eating problems, emotional functioning, digestive problems had some impact on quality, but not as much as everything you see to the right. So the worst was physical functioning, but also weight, treatment burden, vitality, health perceptions. And just to give you kind of context, the clinical participants that were going to enroll in Trikafta studies but hadn't yet received their modulator therapy, they had higher baseline CFQRs, like in the round 76 for physical functioning. So already this is just a much sicker population. And then CFRSD CRIS scores, again, that's looking at your severity of your symptoms over the past 24 hours. This scale kind of goes the opposite. As you go up, you feel the worst. That ranges from 0 to 100. So the highest severity score was feeling fatigued and tired, seconded shortly by coughing up mucus and cough. And so on the right, you look to see that their average score was about 45. So again, 0 is you're feeling great, 100 you're feeling worse. And for context, for the STOP study, so our clinical trials when we looked at different durations of IV antibiotics, so basically people were starting on IVs, they started at a CFRSD score of like 47, and at the end of their IVs, they went down, they improved to 22. So again, this population is starting off feeling as bad as people were admitting to the hospital. And then looking at their treatment burden across CFQR and the newer CFIQ treatment, basically we're showing here that there is a significant amount of treatment burden. They reported that their treatments require about 3 hours per day. And so both burden scales are showing that we have significant burden due to the time and energy that it takes to do their treatments. In addition, the last patient-reported outcomes show we have high activity impairment, anxiety, and depression. So in the middle, 54% reported that they scored that they were impaired on their ability just to do their daily activities. 56 scored mild to moderately severe on depression, and 50% mild to severe anxiety. And so what are they telling us in interviews? So again, when we do the qualitative interviewing, we're kind of trying to identify themes that keep coming up. And so these are the themes we identified. And so the first one, high symptom burden. A lot of respiratory symptoms. I get chest tightness, wheezing, and I cough up a good deal of sputum, just thick, sticky, and gross. He was 26, is 26. Negative emotions. I was in a very negative state of mind when I remember I'm not living the normal life. I see other people doing stuff that I really can't do, and it takes a toll on me. She's 22. Trouble with physical activities. My friends are on these amazing, epic hiking trips, and there was just no way that I was going to physically be able to do that, no matter how active I am. She's 35. High burden of available treatments. So where we said on average they're spending 3 hours a day, if they're sick, this gentleman said he can spend up 6 hours a day just doing treatments. Social life barriers. They get calls, 6 o'clock, let's go get ice cream, let's go to the movies. I literally cannot handle anything more that day. That was a 28-year-old female. Challenges with work or school. After high school, I realized I was probably too sick to be spending thousands of dollars on college at the time, so I didn't go to college. He's 26. Challenges related to healthcare. This 68-year-old female said, my previous 2 places, they just weren't as good as the place I go to now. It just didn't work. It's like having a bad doctor who doesn't hear you and you say, I gotta fire him. And here's additional quotes that I think are really important and kind of, I love hearing their voice. It's very hard seeing all these people on modulators. Sometimes I feel like there's just nothing for people like me. I went to college with someone who's on a modulator and has no CF symptoms. I'm jealous. I hope there's stuff in the works for people like me. And I will say the majority of participants were very happy for other people. They just want something for themselves. I want a modulator. I see it work wonders for people, and I'm happy for them, but I want one too. You know what bothers me the most? It's that all this junk that I have in my lungs and people with modulators don't. That bothers me the most, knowing that I haven't had a fit for my mutation. Modulator drugs have been very helpful for a lot of people with CF, but because my mutation is very rare, none of them will work for me. I'm still doing a lot of the older CF treatments, and they're not as effective. I do everything, and things still get worse. When I found I didn't qualify for a modulator for a while, I had a sense of my life foreshortening. She's 69. When Trikafta came out, everyone's like, oh, you've got a cure now. It's great. And she says, yeah, no, that's not me. That sucks, not having something like Trikafta to kind of help. So in conclusion, we're seeing from this study that there's still a very substantial disease burden, negative quality, an impact of quality of life. And I think we can all agree this is the most significant unmet medical need in our community. And I know we've heard about it a lot, and the next plenary this afternoon is going to focus on a lot of that as well. A few limitations, they were self-reporting that they weren't eligible for modulators. We did not independently verify, and the sample size was small at 16, but we did reach thematic saturation. So I'd like to thank CFRI and Rare Patient Voice who helped us recruit, and all 16 of you that participated. I hope they're listening online to know that their voices are being heard. And the study was also supported by Vertex. So, thank you.
Do we have any questions for Dr. West?
I think we're all pretty familiar with the CFRQ, but you mentioned the CFIQ, and this was the first time I've heard of that one. Can you just kind of
Yeah,
tell us
so
a little bit more?
it looks at, so I had to have a cheat sheet on all these things. I didn't just memorize all those. I promised myself I wasn't going to show you guys that. But it's called the Cystic Fibrosis Impact Questionnaire. So I believe it was validated just 2 years ago or so. And it's just looking at how your activities at work, school, classroom are impacted. So it's just recently validated. So we don't have anything to compare it to from other studies like we do CFQR and CFRSD, but
Yeah.
it's relatively new.
Nothing yet. Yeah, I don't know about y'all, but hearing some of those quotes just kind of gave me chills. And I think it just kind of highlights the importance of kind of qualitative and mixed methods research in studying, all health conditions, but especially in this population. So, if you're interested in kind of pursuing this type of research, I've got a friend that did I know she did an online certificate program in mixed methods research. And so, if you're interested in, you can see yourself kind of doing, maybe you're not basic science, but it's like, hey, I'd like to learn how to do this one day. There are avenues out there to pursue it. So I think this was a valuable insight to hear. So.
Thank you so much for giving these patients a voice, because that was super impactful. I know my heart just kind of sank hearing that, because we don't usually talk about that. We see the patient for an hour, but this is their life. And so it's really important for us as their therapist, as their care team, to understand that we only see it for an hour or so, but this is the rest of their life, and be mindful when we have our conversations in the clinic. Thank you so much.
Yeah, thank you.
Yeah, so I hope everybody enjoyed that, because guess what? You're going to hear some more quotes coming up. So I'm happy to introduce Christina Roman. Is that correct? Christina earned her master's in public health in 2013 from the University of Colorado at Denver, and has served the CF community since then. So she's been doing CF work since graduating, and is now the Senior Director of Community Insights and Partnering at the Foundation, where her work included, I know many of you have probably heard this, the kind of developing and overseeing the Community Voice program which is utilized to kind of integrate CF research, care, and community initiatives. And she's going to be presenting Foundation's research on the Foundation's research on perspectives of people with CF that are CFTR ineligible. And we especially want to thank her for getting ready at the last minute to do this presentation. And well, wasn't actually the last minute. She had 2 weeks notice. So thank you, Christina.
Right. Well, you're going to hear a lot of similar themes to Natalie's presentation from me.
Sorry, I forgot to get you started.
Oh, push start. Oh, sorry. Thank you. All right. So before I jump in, I have to acknowledge that most of the work that I'm presenting today is actually the work of Jessica Hudson, whose leadership and contributions were central to this. And unfortunately, she wasn't able to be here to present, which is why I had to pull this together at the last minute. And then also all of the community members who have shared their time and perspective and lived experiences through the interviews I'll be presenting and then some additional survey data. So to get started, this work that was led by Jessica, as I mentioned, was done through the CF Foundation to really better understand what are the engagement experiences from those who are not benefiting from CFTR modulators, how are they receiving information about research, and then what are their interests and barriers in participating in genetic therapy clinical trials. So a lot of the interviews focused on research, but I'll focus today on sort of more the lived experience as it's relevant more for this session. So the first round of interviews were actually done back in 2023. 27 structured interviews were conducted. We recruited through the Community Voice program, as well as small group recruitment through CF Circles, which is a program the foundation does. And there were circles for people that weren't benefiting from modulators, so they were informed about this opportunity. Interview data was analyzed using inductive thematic analysis, and we had 23 adults with CF, 4 parents that participated in those. Majority of the participants in that round were white, 2 identified as Hispanic Latino, and then it was a mix of both people who were not eligible due to mutation and those who had discontinued because of side effects. So one of the things that we noted was that there was a lack of representation among people of color, which, as Natalie noted in her last presentation, they are more likely to not be eligible. So we wanted to make sure we really were capturing those perspectives, as they're also critical to understanding the experiences of the community that we that needs additional understanding. So we did a second round of interviews in 2024. Those were largely recruited through, again, Community Voice, but also through CF care teams. So thank you to the care teams that helped us push that out. And in that population, it was more parents that participated than adults with CF. So something to just note as I walk through the data. We had 6 folks that were Black African American, 3 Hispanic Latino, and 1 that identified as South Asian. And in that population, all were not eligible due to mutation. Okay, so digging into the data a little bit, one of the questions that was asked was just about what this population's feelings about being represented in the community and in CF research. And so within the first round, majority of participants expressed negative and ambivalent feelings when asked if they currently felt represented, and expressed that they really felt like there was a disproportionate emphasis on those who are benefiting from modulators. Interestingly, those that had to discontinue due to side effects had a much higher percentage of negative comments throughout the interviews, really feeling like their perspective, their experience hadn't been validated, that they hadn't been taken seriously, and they really felt left behind. And, you know, similar to what you heard in the last presentation, many people, while they did express feelings of being deprioritized, they also said that they felt like there was some hope and they were starting to see some changes and increased focus and visibility for their communities. So just to read a few of the quotes, a tiny little subset of us have had to stay on the Titanic. Everyone else got the lifeboats, and we're supposed to be happy for them, and we are, but it's rough, including listening to everyone else celebrate. We've gone through the stages of grief. We were a big CF family all together, and now we're not anymore. I told my parents I can't do this. And this last quote is from somebody that had to discontinue due to side effects. I told my parents I can't do this anymore. And even my doctors, like, maybe we could try again after we do this. they don't understand the mental toll that it takes to go through something like that. So every time they're like, oh, you can try again. And you're like, okay, you weren't there. You didn't experience it. And I don't want to risk that again. Similar questions, but for the second round of interviewees, people that identified as folks of color, majority of participants had similar sentiment, expressing that they've had negative feelings when asked if they were felt represented by the community and in research. Many felt left out of research due to a focus on the modulator eligible community. They expressed that they didn't feel like opportunities were communicated with them, that their perspectives were deprioritized, and a few did note that they felt like getting involved in programs like Community Voice and seeing things on social media gave them some hope, like there was more of an effort to reach out to communities of color and to people that weren't benefiting. Again, some quotes. I know there's research being done for other mutations, but you just don't hear about them as often as others like the main mutation. We want something. We want some type of proof that it's moving along instead of just being told this constant hope. I do feel like we're getting kind of left behind a little bit. I'm so tired emotionally, so I don't know if it's me feeling that way because it just hits so close to home. Okay, so we also asked about where people are getting information on research and their interest in research. And so in the first round, almost all participants expressed a lot of interest in learning more about CF research. Some common themes included information being scattered and inconsistent and hard to find and not lay-friendly. And few had heard about research from their care teams, despite that being their preferred source of information. It can be a little discouraging to hear for many years, oh, they're working on this and it's promising. And I'm like, okay, that was 2 years ago. Research is more scattered. It's easier to find information on what they're doing with modulators than information on those not benefiting from them. My care team, I just don't trust them to give it, being research information, to me because they haven't done a good job of that in the past. I just think they either forget or they think it's not important enough or they give me not enough information. My biggest concern is that I'm missing a ton of things related to those not eligible for modulators. I usually stumble across information haphazardly or what seems by chance. And again, in the second round of interviews, similar themes, but participants were even less likely to be aware of genetic therapy research or informed about research from their care team. So often the answer to this question was like, what do you know about genetic therapies research? And the answer was just like, nothing. And while some indicated that information was currently meeting their needs, many expressed gaps in information, including it not being lay-friendly, feeling like they were missing important research updates, or that information was really hard to find. So again, a quote, not really, that's why I use mom groups, because they can kind of break it down, what it means and stuff. Sometimes the wording is a little big. So again, just not being able to comprehend some of the language that was being put out. I wish I didn't have to look through Google because the foundation isn't giving everything they have. Obviously, there's a lot of stuff that's getting research, but some of the stuff therapy and stuff, I just don't see it much. So again, just not feeling like they're getting the information that they need about research. So some key takeaways from this interview work, there are really strong feelings in this community about being left behind, feeling deprioritized. Those that are eligible and not taking due to side effects feel even further isolated and silenced at times. Many are cautiously hopeful based on recent improvements in communications and research development and programming for this population. And so that those educational materials and increased focus on support for this population is so critical and really has made strides, I think, what we saw a little bit, but certainly there's a need for a lot more. And then among the second round of participants who identify as people of color and or Hispanic Latino, they were even less likely to be informed about their mutations. They were less likely to be engaged with the CF community and informed about research. And while many expressed a hesitancy to participate in early phase research, they expressed very high interest in learning more and wanted to see hope in work being done for them. Okay, and I just given the topic area of this session, I did want to share some additional supplemental information from a recent CF Foundation survey that was done. If you were here last year at NACFC, you probably saw it advertised. This was a large survey that was done to inform the Foundation's next strategic plan. And we saw a lot of these themes bubble up there as well. So I'm going to walk through a few of the questions and some of the analyses, particularly on those that are post-transplant and not benefiting from modulators. So again, this survey was fielded last fall. It included the full CF community audience. We reached out to people living with CF, caregivers, care teams, researchers, CF Foundation staff, and volunteers and donors as well. And then the distribution, we sent out emails. It was distributed through care centers, social media, and events like NACFC. So this is the demographics of the survey. I'll just be sharing information from the caregivers and adults with CF. So one of the questions that we asked was perceptions on care teams. And so you can see here that overall impressions of CF care teams is very high, with majority of respondents saying strongly that they feel like their care teams are trustworthy, they're including what matters to them in decision-making, helping guide them to resources to help them manage their CF. And there was slightly less agreement with being connected to CF Foundation resources, but still quite high. Okay, and then in these charts, just to orient you a little bit, the dark blue dots are those that are taking a modulator, green dots are those that took in the past, and purple is folks that have never taken, largely due to mutation. And so you can see here that the trend is that those who aren't benefiting from modulators are expressing, while still pretty high agreement, it's less so than those that are benefiting from modulators. So feeling a little bit less trustworthy with their care team, that they aren't included as much in decision making, and less agreement that they're being connected to the resources to help them manage their disease, and certainly less informed about clinical trials. Again, this is comparing adults with CF in the purple dots, and then those adults with CF who are post-lung transplant. We weren't able to assess based on advanced lung disease. We didn't ask a question about whether or not people had advanced lung disease, but you can see here, and I would imagine that the findings would probably be similar in the ALD population as well, that those who are post-lung transplant, again, are expressing lower levels of agreement across these questions. We also asked questions about finding resources and information. So you can see here again that adults and caregivers generally were able to find information on a variety of topics. But when we looked at it based on modulator status, so this is a little bit hard to read. This is folks that expressed finding it very or somewhat difficult to read. So higher numbers mean they had a more difficult time finding information. And so again, you can see here that those that aren't benefiting from modulators seem to be having a slightly harder time finding resources for themselves. And again, you see that trend with those that are post-transplant. And another question that we asked was related to common concerns and challenges that people were facing in managing their CF. And so you can see here we asked on a variety of topics how burdensome they were for people in their day-to-day lives. And so across the board, in pretty much every population, we saw that digestive system complications were the most burdensome challenge faced by majority of people, followed closely by managing the coordination of their CF care. So not even the symptoms themselves, but just managing the healthcare system, which I'm sure many in this room can relate to. And then when we looked at these by modulator status, again, you can see here how striking it is that those that are not taking a modulator, both because they took in the past and had to discontinue, or they haven't been in a modulator due to mutation, are facing a much higher level of burden across many different domains. And we see this again with those that are post-transplant. So you can see here that for the post-transplant community, again, they're facing many areas where their symptom burden and the challenges that they're facing are much higher. So just in summary, those that are post-lung transplant, as well as those that aren't benefiting from modulators, do tend to report a much higher level of burden and challenge than other populations in finding resources and feeling like they're getting what they need from their care teams. These populations are facing a much higher barrier, and it's common for them to be feeling left behind or forgotten in the CF community. This QR code is something that we have where if you're interested, you can scan it, and there's a ton of resources that we have for these communities. So if you fill out, there's a little survey, and then we'll send you some of the resources that we have available. I think one of the key things is just how important it is to be informing and really attentive to the needs of these populations who are certainly facing both more of a physical burden from CF, but also just the psychosocial and really needing a lot more support. So that's all I have. I'm happy to take any questions.
Checking here. Once again, thank you for stepping in with 2 weeks' notice. That was wonderful. Thank you.
And yeah, from your research, it seemed like the patients were expecting the CF care teams to provide information about potential new medications and modulators and ways to help manage their disease. They were Googling resources, and so the last slide here, you have a QR code. So is this something new that's developed since your research, or since people were reaching out? I mean, because it seems like the foundation would be like the go-to place for the patients.
Yeah, I mean, I think it's hard because I think some of what we saw was that people, a lot of our resources are for the whole community, right? And so finding the resources that are tailored for people that aren't benefiting, because I think the psychosocial burden, and you saw that in the quotes that Natalie shared and some of the quotes here, of just like not really wanting to engage when it's when they feel like it's all about modulators. And so I think it's about like directing people to the right places. So the QR code will help you. We can share resources that are more specific to that community, help get people connected to things like the Clinical Trial Finder, where they can learn more about research that's happening for them, or small group discussions that are geared towards people that aren't benefiting. So we've always had these programs, but I think it's the way it's communicated and making sure that they feel like there's a space for them where they won't have to deal emotionally with the difference in what their disease experience looks like compared to those that are benefiting from modulators. If that makes sense.
Yes.
Yeah.
Very much. Thank you. Thank you so much.
All right, so last up, last but not least, we have Amy Van Zee and Katie Hall. They are both licensed master social workers that work for the adult CF care team at the University of Michigan's Medical Center. They have a combined experience of over 30 years as medical social workers, and each has over 10 years of experience working with lung transplantation specifically. They bring deep expertise and compassion into their role. And as Amy says, she considers it a privilege to walk alongside individuals and families throughout the transplant journey. So your patients are lucky to have y'all as part of the team. So Amy and Katie both offer empathetic support, advocacy, and guidance in the transplant process. And in their presentation today, they're going to offer innovative strategies to help our patients with advanced lung disease by enhancing collaborative efforts and empowering patients with vital knowledge to improve their health outcomes. So welcome, Katie and Amy.
So we do not have any relationships to disclose related to this presentation. So I am the social worker and program coordinator on the adult CF side, and Amy specifically works with the transplant population. We wanted to make sure to recognize our teams, because without them, Amy and I couldn't have done the work that we've done. It all started with QI initiatives from the CF team, and then going to a collaborative between the CF team and the CF lung transplant team. And now Amy and I have branched off. And if you want to know any more about some of the educational things that we do, check out poster 424. So shout out to our QI team. So why did this initiative start? So to close the gaps in understanding, reduce anxiety, and support CF patients through the lung transplant process. So we, our CF team initiated a QI project in 2018 where we had recognized that our program was not great at referring patients in a timely manner for lung transplantation. So we worked at trying to figure out why is this happening and then how can we fix this? Because not only were we feeling anxious about lung transplant, our patients were feeling anxious about lung transplant as well. So in 2020, after we had done a little bit of pre-work on the CF team side, we joined forces with our CF lung transplant team and came together to continue to optimize the process. And then in 2025, that's when Amy and I began working on focusing on anxiety in the advanced lung disease population, as well as doing a look back at the past patients who have been transplanted in the last 5 years. Intercenter collaboration, why it matters. So we all know that everybody communicating with each other and being on the same page is ideal, but it's also very difficult to actually bring to fruition. So we had to really work hard to get our teams on board, as I'm sure all of you do whenever you're trying to make some big changes. I was at a presentation yesterday where somebody said, who has time for QI? You do. And was able to sort of pinpoint all the different ways. And so we had to do that as well, and really trying to identify and highlight why this is important. We wanted to make sure that our teams were all presenting the same information to patients, that we were coordinating with each other so that we weren't saying different things or requiring different things of patients. We wanted to reduce the anxiety for our patients. And, our ultimate goal is better outcomes for our patients, and we want them to feel empowered. Our CF team in 2018, 2019 timeframe came up with educational materials, and we decided as a group we were going to provide education annually to all patients with CF, regardless of their FEV1 or symptom burden. How we did this is that our clinic nurse provided education for patients who had an FEV1 of greater than 50. And then their physician provided education for those with an FEV1 less than 50. We had surveyed our patient family advisory board, and they had really emphasized that they wanted to be hearing from the provider when transplant was actually something that is on the table in the future. And so that's where we decided to make that shift based on their feedback that they provided. We administered pre and post education surveys to assess where patients' knowledge was, as well as their anxiety about talking and thinking about lung transplant. And so after we had successfully implemented this education process, we decided we needed to expand our efforts. And so we worked closely with our lung transplant colleagues and their QI team to join forces and come up with a larger collaborative approach. So we identified that we wanted all of our patients with an FEV1 of lower than 40 to be seen annually by our CF lung transplant physician. We had found that our patients were sometimes being referred, sometimes weren't. How often do they go back? And so there was a lot of confusion about that. So we set the standard that the lung transplant provider would assess annually, and if there were greater needs, then they would be able to, they could always see the patients more frequently, but 1 year was the maximum time we wanted before the lung transplant provider took a look at our patients to weigh in on next steps and what we could do to enhance the patient's care. The other thing that we decided was our CF and CF lung transplant teams were going to meet 3 to 4 times a year to review the advanced lung disease, to review patients meeting the advanced lung disease criteria and ensure that both teams were on the same page. So the other thing that we found is that when our patients were meeting with the transplant team, that sometimes the information our team and their team were providing were different. And so we had to make sure that we were on the same page. And so we made sure to run through our patients together and found this to be really helpful to come together as a team. Another thing I had heard was that in a lot of sessions with Zoom meetings is that people have the black boxes. And so it's hard to really get that engagement. So I just wanted to throw it out there that we always meet by Zoom, but we all have our cameras on. And so that keeps the engagement, and that has really helped our team to be able to make sure everybody's there participating and engaging in the dialogue. Unfortunately, in 2024, we lost a patient who was about a year post lung transplant, and our team decided to do an M&M to review what went wrong in this situation. One of the things that was identified was that the patient had depression and anxiety that were not well managed, and while we were aware of this prior to the experience or prior to transplant and through the transplant process, we identified there were ways that we could improve what we are providing to our patients. So through that patient's journey, that's where Amy and I decided that we really needed to make sure we were addressing patients' anxiety needs. And so we focused on patients with meeting the advanced lung disease criteria, as well as looking back at the patients who had been transplanted within the last 5 years to learn more about their experience and their anxiety. We have about 39 patients who meet the criteria for advanced lung disease, and 60% of those patients self-reported having a high volume of anxiety on a regular basis. And when we took a deeper dive, we looked to see that only 5 of them were seeing a therapist, and we had 19 patients taking psychotropic medications. Some of those were from patients who did not self-identify as having anxiety. And then our mental health coordinator had only seen 7 of those patients as well.
Okay, so next up to talk a little bit about our survey. Like Katie said, over the last 5 years, we looked back and we had 8 patients who had cystic fibrosis who were transplanted at our center. We had 5 that completed the survey, 2 that declined, and then 1, as we mentioned, unfortunately is deceased. The survey included 16 questions grouped into 3 different categories, the first being emotional readiness and anxiety. We wanted to understand how prepared the patients felt before the transplant, how they managed their anxiety, and what emotional supports they received. The second category was education and knowledge. This section explored how clear and comprehensive the pre-transplant education was and whether patients felt informed about expectations, risks, and the recovery process. And then the third section was support and resources. We asked about the quality and accessibility of support from both the CF and the transplant teams, as well as from peers and community resources. Our main goal was to identify both the strengths of our current practice and also any gaps that we can improve for better journey for the transplant patient, for also their post-transplant beyond that first year, their outcomes. So with this background, let's look at what we learned from the survey responses. The feedback from these 5 participants provided valuable insight into what aspects of our transplant education process are working well and where there may be opportunities for some strengthening, which goes back to Abigail's information too, that mental health is definitely an area that we can definitely bolster. The first area we decided to study and further look into was emotional readiness and anxiety before lung transplant. Participants were asked to rate their feelings on a scale of 1 to 5, where 1 was totally calm, cool, and collected, and 5 was extremely fearful and anxious. Overall, most responses were reported at a level 5 prior to education, indicating anxiety remained a common experience leading up to transplant. And then the majority of reported scores lowered to level 3 post-education, with all responses lowering levels of anxiety and fearfulness to some degree. Several participants mentioned that even with thorough education, the uncertainty surrounding the procedure and recovery contributed to ongoing anxiety. This just highlights the importance of addressing emotional readiness as part of the education process. And really identifying and helping them identify realistically what it's going to look like after transplant. So again, going back to in the room that we're at, like what it's going to look like post-transplant, how maybe I can't lift a soup can after the recovery where I was lifting huge weights before. It's looking at what it's going to look like actually post-transplant. Okay, and then translating results into practice. Our study results showed that education and collaboration reduce fear and improve readiness for transplant. Translating this into practice means making these strategies part of a routine care, not just a one-time initiative or a one-time conversation. So as Katie mentioned, we kind of have the ability at our center, because we have a CF center and the transplant center all in one. But just having that consistent collaborative effort, consistent messaging is super important. Even small steps like sharing check-ins and consistent educational handouts. A lot of transplant centers have educational information. So even obtaining that as a CF provider and using whichever center you're going to you're sending your patient for transplant, using their material so that you're using the same information and consistent information. I think really and truly believe that the key component is collaborating with your transplant center. Okay, and then expanding our initiative, what is next with our collaboration? This highlights the importance of addressing emotional readiness as part of the education process, not just providing information, but helping patients to really build those coping strategies and realistic expectations. Most participants rated their knowledge between a 1 and 3, indicating the overall education was strong, but a few noted gaps in specific areas, particularly regarding long-term recovery challenges and what daily life would look like after transplant. Some feedback suggested that information overload close to the time of surgery made it difficult to absorb everything, and that reinforcement post-transplant is helpful benefit from the transplant team. These findings suggest an opportunity to extend education across the continuum of care, not just pre-transplant, but also to include education on what to expect in the early months of recovery. Several people also commented about peer support. And interestingly enough, in transplant, my world of all lung diseases, we've actually connected some CF patients with some peer mentors that are non-CF and have built beautiful relationships because they can meet together and one-on-one so they can actually physically be with someone. And we've also connected then CF patients who've had a transplant and not, virtually. And we've had good success with that in different ways of navigating that. Okay, and then applying this work to your own setting. Like I said, when we first started this work, even with our roots in Go Blue and we're all together, it was still, there's this fine line, looking at it from a bird's eye view of, you have the CF center who's been caring for this person for however long, and you care so deeply and so much, and you're so committed, and it's so beautiful, and it's a different kind of medicine and like a different kind of relationship you have with patient compared to other, types of medicine and patients that, you care for. And then same with transplant, we care very deeply for our patients. In lung transplant, we follow them forever. We are with them forever. We see them every few months for their whole lives. Their organ means so much to us. Their lives mean so much to us. We see them do things, getting that lung and living their lives. So we have these two teams that are so deeply invested, but coming together can be a challenge, right? Because they both care so deeply that sometimes it's like, it's hard to make that connection. So coming from just reaching out and trying to find a way to connect in some way,
just offering that olive branch to kind of connect in a way, because at the end of the day, everybody wants to see that person succeed at the transplant, and that's the ultimate goal. And to just recognize that the patient outcome and seeing them, graduate college or walk down the aisle or see their grandbabies or whatever, that's the ultimate goal, and working together is what's going to get us there. I think that's it. If you have any questions, I know this is like a different world that we're like talking about social workers, and I can say thank you to all of you, because during support group meetings and stuff, our patients always mention that they love their PTs, they love their RTs, and they get to know you all really well. So thank you for all that you guys do.
Thank you so much. And yes, this is a very different session. So thank you all for being here. I wanted to ask, so in the post-transplant, are they still connecting with the CF team?
Yes, so that actually was something that we worked on jointly as well with our CF and lung transplant team. So we went back 5 years post-transplant, and all of those folks, we sort of had this like, hey, we're going to have you see the CF team still, and like kind of revert back to that. Everyone who was beyond that, we gave the option. So some people did want to see the CF team, some people didn't. But it's kind of hard to ask somebody who hasn't seen a CF team in 20 years to go meet a new CF provider, because their provider might not even be there. So,
okay. Next, real quick, maybe more a comment, the importance of still doing like pulmonary or airway clearance post-transplant, because we know new lungs, but how is that being addressed? Like, are RTs and PTs still being pulled into that conversation?
Yeah, so we have a physical therapist and a respiratory therapist at our center. And so a respiratory therapist sees the post-transplant patients annually. So even if they're not seeing the CF, I should have mentioned that. So our CF team and transplant team see patients in the same location on the same day. So we easily can have parts of our multidisciplinary team go in. So while our patients had stopped seeing their CF physician, they were still seeing other members of the care team. Social work was probably the one area where it was more delineated between who was going to do what. But we're sort of recognizing that we need to come together with a more collaborative approach through this process. So as social workers, we can continue to help support our patients. But yes, our multidisciplinary team has always continued to see post-transplant patients.
Any other questions?
We're just curious if you have any recommendations to those locations that don't have their CF care center and lung transplant so close together. If there's a bit of distance, how to continue that collaboration.
And yeah, just to make sure everybody listening online has heard the question, is what about centers that don't have a transplant and a CF center together? How do you facilitate that collaboration?
Yeah, so I think that trying to reach out and with a point of contact to initiate this process, but meeting virtually helps significantly, and having the buy-in to have your cameras on, engaged, everybody coming prepared, and really being able to collaborate. Our teams have also participated in a lot of the different QI initiatives through the foundation, and one of those which was a joint CF and CF lung transplant initiative. And so through that, that's what sort of bridged us. And so potentially, looking at participation in a program like that, where it really forces you to regularly be communicating. But I think that Zoom would probably be like a good platform to be able to have meetings. And the way that we run our meetings is that the CF team, we go through and update information on all of our patients. So the transplant team comes and acts more as advisors for what we're hearing, or what they're hearing. So we sort of present when is the last time that they saw the lung transplant team, when is the last time they saw the CF team, and then we talk about what barriers to transplant exist, what's medically going on, and that's where we sort of get that collaborative approach from both the transplant and CF side. We do have all members of the multidisciplinary teams participating, and I think that that is essential. Part of the reason we do an FEV1 of 40 as our main criteria, and of course our providers are, looking at other things, but with an FEV1 of 40, any member of our team can identify, like, hey, we're missing this with this patient, or hey, their FEV1 has dropped to 39%. They're still not being talked about. We need to bring this person to the table. So the CF team running it and then having the transplant team there to collaborate, I think that would be a successful way, but it really starts with having one person on the team willing to take the step to reach out to either the transplant team or the CF team to sort of say, hey, we've got to figure this out and make this work.
That was my next little comment. I was just going to say, from the transplant side of it is just connecting. So like a social worker, there's the Society of Transplant Social Work. So there's a lung transplant social worker, part of all the team. So like when we were looking at some of the data, like adherence issues and mental health, we don't want to say no for a transplant. We want to say it might be a not yet. So if we have time to be able to work towards getting you to, yes, we can transplant you, we need to know ahead of time. So the earlier we can know, and each center has different kind of wiggle room on their guidelines for what adherence looks like, what social support looks like. So connecting with the social worker at that center to find out what those guidelines are.
Thank you so much, ladies. Appreciate it.
Yes, and thanks everybody for attending. I hope you learned some valuable information today that you can take back to your own centers and enjoy the rest of Saturday and safe travels. Anybody's leaving this afternoon.
Thank you so much.